This is starting lens determination for V551, ocular motility and refraction. What is the starting lens? It is your best estimate of what the patient's spectacle prescription is before beginning subjective refraction. Why do we need a starting lens? Well, let's take some examples. 99% of the population is within plus 4 diopters to minus 10 diopters in quarter diopter steps. 0 to 3 diopters of astigmatism also in a quarter diopter steps. 180 degrees of rotation, and almost everybody has 2 eyes. That means there's over 242,000 possible lens combinations for most of the population. It is logistically impossible to attempt all these options subjectively. So a good starting lens limits the time spent on subjective refraction by limiting it to a few limited options. Well, what options are there available for a starting lens? There's the patient's habitual prescription. That means what they're currently wearing when they came into your room. You could use retinoscopy, which is a large part of this course, as well as you could use AutoRefraction. All of these provide a lens we start with by putting it into the phoropter as our starting lens before we start refracting. Now, I personally use habitual lenses whenever I have a choice as my first option, and that's because its strengths, it is exactly what the patient has adapted to, it's what the VAs were taken through, and it's what their chief complaints are through. It also is what the VA's change is showing you, so it's the best predictor when you try to use VAs to predict the prescription. Essentially, you already know how the patient sees through it and what changes to make. Typically, there are very little changes in habitual RXs over a few years. It does have some weaknesses, though. If the glasses are very old, it can be not very accurate. If the patient brings in a pair of glasses that are 10 years old, it's probably not the best starting spot. Also, large changes in refractive error due to disease, so increases in sugar may cause the myopic shift due to diabetes, or changes in the lens structure due to cataracts, it may not be the best choice when there's significant large changes or large decreases in acuity. The retinoscopy, which we will be focusing on most of this week and next week, has some unique strengths that are only for optometrists and ophthalmologists. First of all, it's not limited by the location or the patient's cooperation responses. All it takes is for the patient's eyes to be open. That makes it a good option for children or patients who can't get into phoropters, patients who can't respond correctly. And that's where you're going to find you use this the most, I think, in clinical practice outside of the optometry school, is in patients that can't be met by the other two options of the habitual prescription or AutoRefraction. Another side advantage of retinoscopy is that it assesses the optical quality of the eye at the same time. Some of the weaknesses, though, of retinoscopy is it's a pretty complex procedure, and so it can't be performed by untrained people. It takes a highly trained clinician, which is what you're going to become over the next few months as far as retinoscopy goes. The third most common way of determining a starting lens is AutoRefraction. This is the one you probably have the most experience with when you went to your eye exams. It can be performed by unskilled technicians, which is why it's very popular. It also provides secondary measurements of keratometry, pupil size, and PD. Most doctors will choose to use AutoRefraction or their habitual prescription as their first option, followed by retinoscopy when the other two options are not available or a poor situation. AutoRefraction does have some weaknesses, though. Sometimes for low astigmatism it's not very accurate, and also it induces the most amount of accommodation, so it actually has the most errors as far as sphere powers go typically compared to the other two options. Having said that, though, AutoRefractions can be quite accurate. Here's an example comparing an autorefractor to subjective refraction, an autorefractor to retinoscopy. If you see here, the sphere power is only accurate about 60% of the time when comparing AutoRefraction to subjective refraction or to retinoscopy. So the sphere power, while somewhat accurate, is not as accurate as retinoscopy is to subjective refraction, which is about 80% of the time more accurate and more compared to 64% using AutoRefraction. Thank you.